In Chapter 2, we're going to review lines and leads. Some of the lines and leads we're going to cover include EKG leads, blood pressure monitor, central venous catheter, temporary pacemakers, and others. First, the hemodynamic monitor. So this is what you see in a room that's basically displaying a patient's medical stability, such as vital signs, including heart rate, EKG, blood pressure, respiratory rate, oxygen saturation, and sometimes more. You have corresponding waveforms that give information about the accuracy of the reading. You want to make sure you have a nice, smooth waveform for the reading to be accurate. And then also there's portable capabilities so that this monitor can come outside of the room with you when you're mobilizing a patient. ECG leads allow continuous monitoring of cardiac activity. There may be 3 or 5 leads on the patient's chest. These display heart rate as well as heart rhythm on the hemodynamic monitor. The leads should be firmly attached to the electrodes. Sometimes these can come loose, and so you may need to adjust or replace them during mobility. Movement can also cause artifact on the heart rhythm, so you may just want to make sure that you have the patient stop every now and then to ensure that the reading is accurate. If this alarms, the first thing you want to do is check the ECG leads and the patient to make sure they're okay. If there's no pulse, you should start CPR and call for help. The pulse oximeter is a monitoring device that will give you information about heart rate and oxygen saturation. Most of the time you'll see finger probes, but there are ear and forehead probes available if your patient for some reason has poor circulation and you're not getting a good reading with the finger probe. You do need to ensure there's an accurate reading. For instance, if a patient has nail polish on, they have poor circulation or skin pigmentation, that can affect the reading. So you might want to remove the nail polish or use a different probe. I want you to remember, though, that the heart rate is not accurate on a pulse oximeter if the patient has an irregular heart rhythm. For that, you would need to make sure you're looking at the ECG. And you also want to monitor the signal strength and the waveform to ensure you're getting an accurate reading on the pulse oximeter. The blood pressure monitor. There's 2 different types. There's automatic and manual. The manual is really most accurate in the hands of trained personnel because there are higher chances of observer error. The automatic is good for screening and for repeated measuring. So for instance, in the hospital, lots of times they will have these cycling to give constant readings every 15 minutes, every 30 minutes, or so on. However, recent evidence does show that automated blood pressure is very similar to manual blood pressure, so almost just as accurate during a standard clinical exercise test. There is some belief that the automatic cuffs are not as accurate with mobility, but there is some recent evidence that's showing otherwise. The arterial line is going to give you a continuous blood pressure reading. You can also draw arterial blood from this. Lots of times you're only going to see this line in an ICU. It's inserted directly into an artery. The radial, the brachial, and the femoral are the most common. Any line that gives you a reading, such as an arterial line, is going to be attached to a pressure bag with fluid infusing into the line. You always want to make sure there's no blood or air bubbles in the line. There's also going to be a transducer. The transducer will always need to be at the level of the right atrium for an accurate reading. All these monitoring lines that have transducers and pressure bags are always going to need to be in the right location for an accurate reading. If a patient has a radial arterial line, sometimes the reading may be inaccurate, but if you extend the patient's wrist, lots of times this will improve the accuracy of that reading. Now, because this is a line in the artery, massive bleeding can occur if it's dislodged. If that happens, you want to apply pressure and call the nurse immediately. Peripheral IVs you see a lot throughout the hospital. These deliver fluids, medication, blood products, and nutrition. They're always inserted into a peripheral vein and usually connected to a pump. Moving the height of the bag can change the rate of infusion if it's connected to a pump, so you always want to ask the RN before you do that. If the patient's not on a pump, you want to make sure you keep the IV bag at least 18 inches above the entry site, and that's to prevent backup of blood in the tubing. You also want to prevent kinking of the tubing, and if the pump alarms, you should call the nurse to come and assist you. If this line is dislodged, you want to apply pressure until the bleeding stops. It's in a vein, so the bleeding is not going to be as massive as an artery, but you still want to make sure you apply pressure. The central venous catheter has multiple purposes. It can be used for input, output, and monitoring. It's used for the delivery of fluids, medication, blood products, and nutrition, also for venous blood draws, as well as continuous monitoring of central venous pressure. As a reminder, normal CVP is 0 to 8 centimeters of water. The central venous catheter sits in a large vein in the neck or the chest, and it goes to the right atrium or superior vena cava. It usually has 2 to 3 ports. You may have heard of the triple lumen. That's a central venous catheter with 3 ports. If this line is dislodged, there is a potential for large volume blood loss, so you want to apply pressure and call the nurse immediately for assistance. The peripherally inserted central catheter, or PIC for short, is a specific type of central venous catheter. It's called this because it is inserted peripherally, but is tunneled internally and ends up in a central location. This is mostly used for long-term delivery of medications. So if a patient needs long-term delivery of antibiotics, for instance, they may insert a PIC line. The PIC line cannot get wet, and it does require specific cleaning and flushing. You should not take a blood pressure in the same arm as a PIC line because it can compromise the integrity of the line. The implanted port, or portacath as some may call it, is mostly used for long-term delivery of medications as well, especially chemotherapy. It is a small drum of plastic or metal with a rubber-like seal and a reservoir, and it can be accessed when patients come into the hospital for delivery of medications. It is inserted under the skin in the chest, and it can get wet, unlike a PIC line. The pulmonary artery catheter, or PA catheter, is a line you're only going to find in the intensive care unit. It's used to monitor and measure heart pressures, and it's an indication of cardiac function and fluid status. If you recall, a normal mean pulmonary artery pressure is 10 to 20 millimeters of mercury. So this is a central line that's in the neck or the chest. It actually goes through the right heart to the pulmonary artery and is sutured in place. It also is attached to a pressure bag and a transducer that needs to be at heart level for an accurate reading. It's really important before you're mobilizing a patient to check the line measurement and also to have the nurse come with you to monitor the waveform during mobility. For instance, if for some reason this line gets pulled back during mobility, the first indication to you is going to be in the waveform because it is sitting in the pulmonary artery. So if it gets pulled back, it ends up in the ventricle and can actually look like VTAC waveform. So you can sometimes see on the waveform if this line is being compromised during mobility. You may need permission from a doctor or a specific order for mobility with this line, depending where you work. And this line is life-threatening if dislodged, so you want to make sure you take special precaution and call for assistance immediately if that happens. Temporary pacemakers may be in place on your patient for a certain period of time to correct abnormal heart rates or heart rhythms. These provide electrical stimulation to the heart, and there are different types. The first one is epicardial pacemaker. These are usually inserted during surgery, and they're a bit more secure, so your patient may be still able to mobilize with this in place. External transcutaneous pacers are big patches over the chest or back that are attached to a defibrillator and can be a sign that your patient may be unstable for mobility. The transvenous pacer is typically in place to correct bradycardia, so you would want to check with the medical team prior to mobilizing this patient as well. If you are working with a patient with a temporary pacemaker in place, you want to ensure that you closely monitor a patient's ECG and blood pressure because some patients are dependent on their pacer. If this line is dislodged, you want to call for help immediately and start CPR if asystole occurs. There are 3 different types of dialysis: hemodialysis, peritoneal dialysis, and continuous renal replacement therapy. The first is hemodialysis. This requires a machine with a special filter that cleans the blood, and it's typically performed over 4 hours, 3 days a week in a dialysis center, or could be done in the hospital while your patient's admitted. There are different types of access. The first one is an AV fistula. There could also be an AV graft or a central venous catheter, which may be tunneled or a non-tunneled one. Tunneled is usually a permanent one that your patient has in place for a prolonged period of time. Non-tunneled is temporary. Now, whether or not we mobilize a patient on dialysis, can be of concern. Some hospitals allow it and some don't, so you want to check with the facility where you're working to see if that's allowed or not. Peritoneal dialysis is a different type of dialysis that uses the peritoneum, or the lining on the inside of the abdomen, as a natural filter for the blood. It can be done from home or while the patient's admitted to the hospital, and its access is via a catheter in the abdomen. The time varies depending on the type, but about 10% of patients use peritoneal dialysis, so it's not as common as hemodialysis, although sometimes it's preferred because there's less disruption to a patient's daily activity, but it's only appropriate for certain types of patients. When patients are in the hospital, it's typically done overnight while they're sleeping. The last one is continuous renal replacement therapy. This is continuous dialysis that you will only find on unstable patients in the intensive care unit that can't tolerate regular dialysis. So think of your patient who may have acute kidney injury or a low blood pressure, for instance. This runs 24 hours a day, and it's done slowly and continuously to remove fluid and waste. Because it's done slowly and continuously, it puts less stress on the heart. There are some studies show that mobility may actually improve the filter life when patients are on this type of dialysis. So we advocate for mobilizing patients on this type of dialysis, provided they have an access point that's safe for mobility. However, most machines aren't portable, so most mobility will need to stay within the confines of a patient's room. To summarize lines and leads, many monitor the hemodynamic state of a patient, such as an ECG for heart rate, a pulse oximeter for oxygen saturation, or a pacemaker for heart rate and heart rhythm. You want to ensure you're getting an accurate reading when you're working with a patient with lines and leads. So making sure the transducer is at heart level, that you're getting a good waveform and signal. It's important to know which lines and leads put patients at greater risk if dislodged. So your pulmonary artery catheter, for instance, that puts a patient at quite great risk if it's dislodged. And communication with the team is very important. You want to make sure you know the hemodynamic state of your patient, and you want to make sure you're getting good, accurate readings with your lines and leads, and you may require assist when mobilizing these patients.